Good afternoon, ladies and gentlemen. Welcome to another episode of Experts Online. Greetings from sunny Innsbruck here at MED-EL headquarters in Austria. My name is Nikola and I am your moderator for today. I am a clinical specialist, part of the image-guided surgery research and development group here in Innsbruck. The topic of today is precision cochlear implantation, and we have two experts who will present on their experience in this field. But before we start, in order to ensure high quality meeting, I would like to ask you a few things, just some housekeeping. First of all, please name yourself. Like in the conference, we would like to know who is coming from which country, a name and maybe an organization next to it, especially for the discussion later on. Furthermore, to avoid any background noise, I kindly ask you to mute your microphone. You can always enable it during the question and answer session. And at the time, please also make sure that your phone is muted as well. And in order to have a stable internet connection, it's recommended to also close all the programs that might be using your internet bandwidth, so that your connection is stable. Your questions and comments are more than welcome, so please write them in the chat, or again after the second or last presentation, you can unmute yourself and ask directly in the meeting. Also, the captioning is available, so if you would like to see the English captioning, you can always press on the CC icon in your Zoom panel. All right, so the topic is precision cochlear implantation. Today we have two speakers. We have Professor Marco Caversaccio from Switzerland, from the Inselspital of Bern, and we have Professor Vedat Topsakal from the University of Brussels. Before I hand it over to our experts, let me just give you an introduction and a few slides on what precision cochlear implantation means for us here at MED-EL. So first of all, we recognize the anatomy variation in patients and different cochlea sizes, and thus we offer a wide portfolio of electrodes of different lengths. We also recognize the delicate cochlear structures that need to be preserved, but also covered at the same time using the electrode, and that's why our design philosophy is also supporting this by providing flexible electrodes. And what precision cochlear implantation means, again, for us is the whole patient journey. So we aim to create tools that cover the entire patient journey and ensure and individualize constant clinical outcomes in the end. The beginning of the precision cochlear implantation starts with the AutoPlan software, with the preoperative planning, where you simply upload your medical imaging data, and the software within seconds automatically 3D reconstructs, makes a 3D model of the entire inner ear, including the scala tympani and scala vestibuli models, and also measures the relevant cochlear parameters as well as scala tympani parameters automatically. In the next step, audiogram of the patient is added in the dedicated module. And finally, using this anatomical information that we received from the preoperative planning and the audiological information that we just entered, the most suitable electrode can be selected in the electrode visualization module. Here, for each of the 12 contacts, the information about the angle insertion depth, center frequency, and scala location is provided in the software. With this, you have enough information to make the choice of the most suitable electrode for your patient, but also furthermore plan for the most optimal surgical approach. The software allows for 3D modeling of the entire temporal bone anatomy, and then combining this anatomical information, we can, and the electrode selection, we can proceed to the intra-op step Here we want to ensure that the surgery is atraumatic as possible, and we have recently introduced the AutoArm system that helps in positioning and orientation of surgical instruments, and also the AutoDrive, which is there for the slow and consistent movement. When designing these two systems, while developing the systems, the main goal was not to block the surgical field, so that we can leave the clear view of the surgical field, that we make sure the surgeon is still in control, and to make these systems easily integratable into everyday clinical practice, so that they are placed in the OR without any big problems. Finally, post-operatively, the software Autoplan allows for a quality check of electrode insertion inside the scala tympani. The electrode 3D model is automatically generated, and angular insertion depth and center frequency are calculated, so the true information from the true post-operative insertion is displayed. This information can come from either a CT image or an X-ray. In both cases, a report is created that can be used in the last step of the precision cochlear implantation during the anatomy-based fitting. So the information can be used to fit the audio processor of your patient. With this, I conclude my short introduction to the topic. And I would like to hand it over to Professor Marco Caversaccio, who is the clinical ENT director of Inselspital in Bern, who will show us how these systems, which are intended for general otology, are used in his everyday clinical practice. Professor Caversaccio, please.
Thank you very much, Dr. Ivanovic. I will show you a little bit the biomedical engineering work that we have performed with this auto-armed AutoDrive, and especially I thank the co-worker, especially Professor Ebischer, Mantakudis, and Vedat, to support our study that we have performed. Next slide, please. As you know, as already said, we have precision medicine, precision cochlear implantation, and what we want especially is for hearing and structure preservation. This is really the objective, to preserve both function and structure. And as you can see down on this picture, that we see that we have with the manual electrode insertion, we have peaks, lead to force, and pressure spikes. Next, please. We have a robotic insertion model that was performed and published on different IEEE paper. This is epoxy resin model on microtomograms. We have a cell load inside and the sensor at the apex as well. We have force control by different measurement. This means we are based what we perform here on this ear model. And we have tested this on 30 manual and 30 robotic insertion by 3 different surgeons. Next, please. This is a realistic temporal bone model, and we have also polymer inside the cochlea. This means we have also friction inside that we can measure the forces, the Newton that we have with manual or with robotic insertion. We have used the Flex 28 electrodes. As I said, we have 30 manual versus 30 robotic insertion. Next, please. What you can see is on the top on the right side, we have control of the forces, pressure. We have also cameras to see the surgical view, the angular insertion depth, as I said, the insertion force, and the intracochlear pressure that you can measure with this ear temporal bone model. Next, please. The results that you have received is the insertion depth is about, not completely the same, but about is the robotic 558 degrees plus minus 25, as well for manual was 565. And the successful tool removal was in 90 of the 30 cases. In one case, we have had a problem to touch, in fact, the posterior tympanotomy. Next slide. What we have seen that the manual is here in blue and robot assisted in red, that you have the angular insertion depth, and when you see these forces that you have every time these small peaks that you can see, this mean you cannot go completely inside in your ear. Normally what they are counting is about 1 millimeter per second, and you can progress, or the 0.89 millimeter per second to go inside manually inside to the inner ear. And in robotic surgery has more a consistent speed. And what we have seen is here that we have a little bit 18% less maximal force with robot assisted surgery. Next slide. Here we have also looked about the angular insertion depth and 95% or 68% confidence interval. And here we can see in blue that we have more variation, force variation, that when we use this robot or telemanipulator assisted surgery. This is to show you that it's better. We have the result 12 millinewton per second versus 33 millinewton per second. Next slide. Here you see the electrode insertion and the angular insertion depth. You see this at the small points in blue, the manual one, and in robot you see in red. You have different pressure of 1 hectopascal to 10 hectopascal. The next slide. And you see the small bombs, what happens. And when you take one of these 30 manuals, one is this strife, you see this correspond about 134 decibel sound pressure level. It's enormous. Next slide. When you look about the surgical steps, what we have looked about, you see highly significant, but certainly the insertion comparison between robot-assisted to manual assisted. What was not significant was the sealing with the round window, the forceps release. This is also one point that it could be crucial, this forceps release, the sealing of the facial recess, and especially the routing cable. Normally what we perform also then in humans is first to make the routing cable. But you see a trend on it, but it's not completely significant. But highly significant was the insertion. Next slide. Now we have performed about 15 cases. You see our hospital in Bern. You see on the aligner the different knobs that you can really precise look how we can go through the posterior tympanotomy. I can say you that the posterior tympanotomy must be large, that you can see with the microscope the round window, and especially then with the clamp that you have, that we have a good access with the floppy Flex 28 to enter inside the round window. What we do, as was also shown by Dr. Ivanovic, is that we put the arm, the auto arm, on the opposite side. You don't destroy the view of the surgeon. Next slide. Here is Professor Vedat is working on it. Here you see the clamp where you fix, in fact, manually the electrode, this Flex 28, to go down to the round window. But as you have seen, is especially all is made, also the sound processor and everything for the cable is prepared. But as you can see, we have the auto arm on the other side where we make the cochlear implantation. Next slide. What we have performed until now, we have the speed was of 0.1 millimeter. During the study, we have used 0.3 millimeter per second. When we are counting the speed of 0.1 millimeter, we have about 4 minutes and 40 seconds. This is a huge, but I think that's what we do. We have also started to implement electrocochleography during the same time. But unfortunately, at the moment, we cannot do the both on the same time, that we can stop completely with the foot switch when we see that is dropping on the electrocochleography. We have used, in this case, in the clinical 12 times the Flex 28 and 3 times the Flex Soft. And what you can see, we have about, not especially, but 102 hours like this to make the operation. What we have performed until now were normal anatomy on the inner ear, normal. And we are looking now forward to look about what happened with the prep on the post-op of the PTA for the 125 to 1000 hertz. Next slide. As a conclusion, then we can say our test setup allows the standardized measurement of intracochlear changes. We have seen that the manual electrode insertion leads to force and pressure peaks. This robotically assisted insertion can reduce these peaks. What is crucial and what is not so easy is the manual takeover adds new challenges. And this means at the moment, several centers that we have also in Bern, successful application of the ARTORG system or in the operating room. But what we must look in the future is the effect on hearing instruction, structure preservation, perhaps in 1 year, because the ARTORG system is one factor to have that we have a normal speed, the constant speed, but there perhaps are other factors for a scar to create scars. And I think this is important to look about these cases in 1 year, what's happened, and perhaps to integrate electrocochleography with ARTORG in an autoplan system. Next slide. When you want to look about what we have performed, you can look in the International Journal of Computer Assisted Radiology Surgery. This is online, is free to look about the results and what we have performed in this vitro assessment of a novel robot-assisted system. I thank you. Next slide. I thank you for your attention, and I'm here to answer your question.
Thank you so much, Professor Caversaccio, and congratulations on this first study. I think on the AutoDrive, on at least on a larger sample patient group. Really excited for the upcoming results on hearing preservation and everything that you're working on. Okay, I would propose now to continue, and then we can answer questions and discuss in after the second presentation of the day, which will be given by Professor Vedat Topsakal from the University Hospital Brussels, who will tell us how he has utilized one of these tools or both tools in intended for general otology in his workflow in order to achieve fully robotic CI surgery. Professor Topsakal, please.
Thank you, Nikola. Am I audible?
Yes.
Okay, thank you so much, Professor Caversaccio, also for lighting your part of the AutoDrive. You didn't talk about Hiero, which is also one of your pioneering works. I would like to go back to a bit more generic thing and state that we are too modest about cochlear implants, which are already very precise instruments, which are the best neuroprostheses in healthcare, in medicine. And we should be more advocating these kind of messages because it's restoring hearing loss. It's a sensory organ. And it has this success due to two things. One of the things is that the tonotopy is all over the auditory pathway. You know, the inner ear may be dysfunctional, but we can still use that architecture with a cochlear implant. And if we more precisely place more electrodes, you know, not one clavier or one touch on the piano, but more, the better it gets and the better the music gets. The second thing is, of course, with very little, the brain plasticity can do a lot. So it's quite a forgiving system, I have to say. Now, if you think, and this is not a scientific slide, but this is a, let's say, suggestion for my part, where do we think this product can be improved? Which fields can improve the outcomes of cochlear implantation? It's just been studied for a very long time, and it's quite a, let's say, straightforward surgery. But yeah, the electrode design, in essence, did not change in terms of you put electrodes inside the cochlea, but we didn't see the downsizing of the arrays as we saw, let's say, in the sizes of our cell phones. So I would really hope for a smaller size of electrodes, and then we can maybe think about preserving residual hearing. The surgical placement, these days we're talking about robotics, but before, the posterior tympanotomy with a mastoidectomy was the standard golden approach. And the surgical placement now, the Hiero system, which I will be talking about, warrants the, let's say, angle of insertion or the trajectories, and AutoDrive also the speed of insertion. Engineering strategies for processors. I mean, if you think of the fact that 1 million people already are using a cochlear implant and you can pull those data, you could probably come up with a, let's say, mathematical algorithm, or if you want, artificial intelligence calculations, that the processors can be programmed more precisely in the benefit of the patients. Or some people are working on stimulating the inner ear with light, and the improvements can come from a totally disruptive technology. Now, this, Nikola also very beautifully emphasized, Autoplan was initially, to my opinion, was designed for robotic cochlear implantation, but it has gained its position in preoperative assessments. At that time, cochlear duct length was a, let's say, hype to discuss about, and also the MED-EL portfolio adapted their array lengths to the measurements we did. Now, it was designed for the Hiero procedure, which I will talk about, and post-operatively, nowadays, we're talking about anatomy-based fitting. Using Autoplan, now audiologists can say this should be the most correct and most precise placement. So there is actually a tool for your cochlear implant program, and this is what I will speak about for the first thing. The Hiero robot, well, a robot actually has a couple of benefits over a surgeon. It is without emotion. It is accurate. It is precise. And if you program it well, it does the same thing every time over and over. So it will eventually standardize the outcomes of cochlear implant surgery. We've also measured lately that drilling a tunnel is less invasive than drilling a mastoidectomy. So it can be more helpful in preserving residual hearing. And we also perform some extraordinary cases with an abnormal anatomy where the robot was actually really reliable in terms of drilling the trajectory towards the inner ear. Now we have not only the standardized calculated image-guided trajectory towards the inner ear, but we also have the standardized speed, as Professor Caversaccio also mentioned, to insert the array. So this should help us in the future, and we see. Here you see the difference between a mastoidectomy and a tunnel or a keyhole surgery as said. And it starts with placing 4 fiducials, as I mentioned also before, I think in online meetings like this, that the placement of the fiducials is not difficult, but it is of utmost importance. Because if you acquire an image and after acquiring the image, you displace submillimetrically one of those fiducials, you will lose accuracy and you may actually endanger the facial nerve. So this is not a difficult step, but this is actually the most powerful navigation system because it uses fiducials, and the placement should be firm and tight. Then we have access to a mobile co-beam CT, which allows us to perform the scan under apnea in the operation theater. It does a trick for us. It has 0.1 slice thicknesses. And when you acquire this image with the fiducials, you go doing the surgery. Like you go from conventional surgery from one landmark to another landmark. Here you have to go and segment one anatomical structure after the other. And then you have to also define which is the most ideal trajectory into that inner ear. Now, to define that trajectory, we are still using the definition coming from the clinics from Professor Caversaccio from Bern. It's a paper from William Wimmer where he did a lot of simulations. And we all agree that we should go through the round window. And the definition for these days says we should stay as long as possible parallel to the basal turn. Now, if we use that definition, unfortunately, the facial nerve is right in the way. So we have to make some angulations in terms of an in-plane and an out-plane angle that we deviate from the ideal trajectory to the most optimal trajectory. And this was Autoplan 1.0. Now, Nikola also showed you the latest version, or also the version 4.0, now automatically segments the anatomy. And it also, Nikola nicely showed you, can account for the residual hearing that was present in that patient's case, can also suggest you the length of the electrode. And if you have all of that, you can simulate and try what would happen if you have a certain length of electrode and you have the suggestion of Autoplan what to do. So you only have to approve or disagree, for what reason or so, that this is not the ideal trajectory or this is not the ideal electrode length. And this will change actually the autonomy of this type of robots. Because if you only approve as a surgeon, you can upload now this trajectory to a robotic arm or to the console, and the drilling is executed completely autonomously. So this is somewhere between level 3 or level 4 of autonomy, and this is different than, let's say, master-slave robots that, like the Da Vinci, these robots will do nothing when the surgeon is not performing or is having a bad day. This robot will have a bad day as well. I'm not saying these are not good tools. It gives the precision and the view in vertical freeze that was not before, but it just to say that this type of Hiero procedures are different than master-slave robotics. Now, the registration with your USB stick will check first two things. It will check if the trajectory that was planned automatically is within the reach of the robotic arm. That can be automated actually, but it will also check if you have preserved a 0.4 millimeter distance to the facial nerve. Otherwise, for the moment, the drilling will not be executed because these are the safety mitigations we have used, at least in the series that have now been performed in 70 cases all over European countries. When that is checked, you start to do the middle ear access. And this is, as I mentioned, the pioneering work of Professor Caversaccio. You have to drill with a 1.8 cutting drill, which is quite courageous actually, through a space of 2.0, or if you're lucky, 2.5 millimeter facial recess. And the only things you have for that is the free running facial nerve monitor. You have the distances and some safety checks. So the first safety check is not only the free running facial nerve, but it is also a customized facial nerve monitoring where you stop and 5 times actively stimulate mono and bipolarly the facial nerve to see how far we are from the facial nerve in terms of milliamps. And you see in the right corner, this is also a traffic light. If you're too close, you will have a red light and you cannot continue. You have to go back and replan the trajectory or convert the surgery to a conventional surgery. Not only that, we also have performed in all our cases hitherto an intraoperative image where we place a metal rod in the tunnel that was drilled so far. And with that, we can also calculate the intraoperative accuracy of the system. And here you see trajectory. If you see the facial nerve is planned of a distance of 0.47, but the actual accuracy was 0.63. So it's a bit further away from the facial nerve and automatically closer to the chorda. Again, a traffic light, we could continue this type of surgery, or this case actually. So now to go from, let's say, middle ear to inner ear, we wanted to be perfectly aligned with a diamond mill to open the inner ear, let's say, the access to the inner ear. And it should be perfectly aligned to have an access of, let's say, 1 millimeter to pass through with a 0.8 diameter electrode array from the Flex series of MED-EL. It's a basic algorithm. We know the depth of the lateral wall of the bony overhang. We know the depth of the medial wall of the bony overhang of the acquired image. And we thought the forces would rise, as you can see here. And when you have a plateau of the forces, we thought we would be in the midst of the bony overhang, and when they drop, you should somewhere add that to the depth and the force drop to stop, not to harm the round window membrane. To explain this, I found it a bit difficult to compare it to, let's say, the conventional way, where we completely take away the bony overhang. So we came up in great discussion, which took 2 years with anatomists from the United States and the Netherlands actually, that we should name or rename this part of the bony overhang as canonus, because canonus is a literal translation of a canopy, where we, in conventional surgery, take away the complete canopy just to look inside, to have an idea on which direction we should minimally invasively insert the electrode. The HIERO system does not need to take away the complete canopy. It just performs a canonostomy. It makes a hole as large as necessary in the correct direction, because the direction, let's say the insertion trajectory or insertion angle, was calculated based on image-guided surgery. So it's even more precise than you could, estimate by the human eye. And here you see such a canonostomy being performed. It's a bit awkward in the beginning because you have to rely on forces and computer, let's say, monitors. So of course we didn't feel comfortable in the beginning, and we used endoscopes. We used also in the first series a second channel to open the eardrum to check what was this device doing. And yeah, we all know that's not really necessary in conventional surgery. So it was in the beginning not so less invasive as we have thought, and it has evolved in between now. I also gave away that we measured the drilling noise, or let's say sound pressure levels, that will be provoked when we do a mastoidectomy. Right side, you see that 3 surgeons exceed with mastoidectomy and canonectomy, I would say, the daily noise levels, whereas HIERO hardly ever reaches the daily noise of 85 decibels sound pressure levels. Does that make a difference? Well, it's just substantiated, and we will see. And we also saw in this study that the force necessary will determine the amount of noise that will be provoked, which is also very logic, but yeah, it really correlates very well. Now, the last step in the HIERO procedures that we performed was a manual insertion. You see here a manual insertion filmed by an endoscope through the ear channel in a cadaver. You see a metal tube, which you will see later on as well. And also the placement of the electrode in the tight pocket and the dealing with the, let's say, insertion tube still remain manual factors. And Professor Caversaccio showed us every movement to the electrode is a force, or let's say, fluid pressure change in the inner ear. So these are things that we really need to understand and standardize, or come up with surgical protocols to improve actually our outcomes. These I will go very quickly over. This is our first 25 series, which we've published, and I can say that only 3 cases needed to be converted. As I mentioned, in 7 European countries now, 70 or more cases have been performed, and none of these cases had ever witnessed any temporary or let's say permanent facial nerve problems. So the system is reliable in terms of safety. And also in our series, we had all full insertions except for 1 case where, let's say, the last electrode was around the round window membrane and the audiologist had to turn this electrode off. So we don't count that one as a full insertion. The accuracy of the system is not the precision of the system. Accuracy is how you use it, and the precision is the standard deviation. So if you look at these 25 series, we had a precision, of 41 microns to the facial nerve and 50 microns to the target, the round window. It's logic. The further you go, the more imprecise the system gets. It just shows that this kind of navigation is really allowing otological surgery. We also followed up these 25 patients for a period of 2 years, and we did not see any long-term or even short-term complications. We did not also see any, let's say, better performance in these cases, because it was just CI patients getting a CI, so they were equally performing as conventional cases. Here you see a case that we did with the HIERO system where the, let's say, front door or the round window membrane was ossified for 4 millimeters. And we thought how to do this. If you are a really well-trained surgeon, you know in which direction you could drill through that ossification. And then, those 4 millimeters can be a bit exciting, but you will find eventually the opening of that cochlea. As we have a system that knows exactly which angle to drill, we planned the trajectory a bit further, and we tried to do this with the ERO system, and we managed to do so. And since we had an endoscope in the room, we also managed to, let's say, film for me for the very first time the intracochlear ossifications. Another challenging case where it's very well known that you should respect the angle of the trajectory that you hit your electrode or push your electrode into the inner ear is an IP3 anomaly. In one of our last congresses, there is actually a training manual actually provided by MED-EL where you can practice these kind of anomalies. And it looks that you have to respect the angle at most. Otherwise, in this case, you can end up with your electrode alongside the meatus acousticus internus. Knowing this and knowing also this anomaly gives a gusher, here we planned the trajectory with the HERO system. We chose actually for a shorter Flex 20 electrode. And we went for a cochleostomy because we thought we could manage through the ear canal the gusher much easily. As we planned this, and that's why I put in my first slide, the system performed very reliable to open the inner ear access, and easily we could have placed it, and the gusher was actually manageable. Now, I mentioned that we opened the eardrum, and this was a burden to me personally because we needed to overcome this, and we needed to be able to do all of these surgeries through the ear, through the keyhole or to the channel that we drilled. And one of the first things that we did is actually improve the HERO procedure with a true keyhole surgery where we, as you can see here, used a normal auto microscope to film and to manipulate the round window membrane after HERO had drilled in a way that you would do it in your conventional surgery. And this was doable. And after that, you see here the insertion through the tube manually. And people said this was a bit of a blind surgery, but it is not, because the trajectory and the insertion tube will guide you through to the inner ear. It cannot go anywhere else. And you have, due to image-guided surgeries, absolute information on the depth you should have of the electrode and also of the size of that cochlea. And imagine if you also combine this kind of surgeries with electrocochleography, this type of surgery is actually absolutely less blind than, let's say, conventional surgeries. So having done that, now we could proceed from middle ear to inner ear, I've shown you, and from inner ear to, let's say, automated speed of insertion or to drive the electrode into the cochlea. If you would say, yeah, but why do I need the HERO? We have the aligner. This is true, but the aligner is probably not as perfectly to be aligned as the HERO system would calculate it based on an image. If you still, let's say, a little bit of a non-believer, I would say, yes, the auto drive and auto arm is designed in such a way that probably you could fit in this operation field some freehand navigation as well. As you can see, it allows for it, but it will not reach, at least in my opinion, the accuracy of, let's say, the navigation system of HERO that uses fiducials. So if you want to use also fiducials in this field, you're probably better off using the HERO for the inner ear trajectory and then do the insertion, which we did. Here you see that we tried for the very first time the auto drive in the conventional case, and now we would want, and this is the post-op image of that using auto blend features, now we would want both of best of both worlds, excuse me, the ideal insertion trajectory and the ideal insertion speed. And we really don't know what is the ideal insertion trajectory or insertion speed, but we think we are approaching to the definitions we use. And that's what we did to minimize pressure changes or to maximize hearing and structure preservation. So we would want both of them to be combined. And here you see the HERO trajectory being drilled, and here you see the auto drive doing the insertion. And we really want to combine this in the future with electrocochleography to see what we can preserve for residual hearing. And that was one of our last papers of our PhD students, Jawad. And this is the post-op image, which I say it's an accumulation of 15 years of research in robotic cochlear implantation. So it's not a one-day development. and who am I to say in front of Professor Marco Caversaccio that this is a continuum of innovations. We slowly, discover which is now the truth for precision cochlear implantation. I thank you for your attention, and maybe stop sharing my screen.
Thank you so much, Professor Topsakal. It's very, very exciting, very interesting approach case. Thank you both for your presentations. Let me see if there are any questions in the chat, or if someone would like to ask something, you can also unmute yourself and in the participants panel and ask a question. Meanwhile, maybe I can. I have a question for Professor Caversaccio. So you mentioned that still an open topic, an open question is the hearing preservation or the structure preservation, and it is something you're looking into. Are there any preliminary results you can share, or maybe the methods you're going to use to evaluate this? I think this will be very exciting to see these results.
I think one is this mechanical way that we have shown you, or with this auto drive, auto arm. It's clear we can also perhaps think to use in the future also this DEX-L with dexamethasone eluting electrodes in the same time. This means we diminish again harm to the inner ear structure. I think so. This could be nice as well. We can also use perhaps in the future also this InCat where we push a little bit inside. The only problem what we see is when you use this InCat, you change sometimes the pressure inside the inner ear, and you push something like dexamethasone inside the inner ear. Mm-hmm. And it's clear that there's a lot of things to develop. We don't know what's happened with scars after 1 year, that we don't go from the scala tympani at this location to scala vestibuli. I think so. When we see the results from other group worldwide, I think we can diminish as well this location scala tympani to scala vestibuli. And I think this will see, especially for hearing preservation, structure preservation, very important that we can use and continue. And it's clear we must also look what happened not only with perhaps coating of this electrode, but also to adapt an electrode, especially lateral wall, for this robot-assisted surgery. This means perhaps we need a lot more. We name these peaks inside, P-E-E-K, to stabilize a little bit the electrode. This means we have other option, I think so, for the future to have better results, I think so, also for the patient. This year, I think we are on the good way. It's at the moment is mechanical. We can integrate this with this electrocochleography that we can stop at the same time when we see a drop in the electrocochleography, also with the auto drive that you can stop at the same time, and compare this also with the auto plan system. I think this will be fruitful of results in the next years, I'm sure.
Yeah, interesting. Thank you. Professor Topsakal showed some audiological outcomes from the hiero surgery. I mean, it's a slightly different topic, but you are definitely the expert there. Did you look into some of the audiological findings in your hiero patients, and is there anything there? I think the combination of ultimately of robotic drilling and motorized insertion will be the highlight. But is there anything you can share on your hiero?
In the first series that we did, these were all patients coming in for cochlear implantation, let's say consecutively, for a conventional way. And at that time, the reimbursement for cochlear implantation was actually not so forgiving for implanting people with some residual hearing. So these were most of them were profoundly or really in need of a cochlear implant, So we've looked at the data, but we cannot substantiate anything. And it was also not to focus on that. It was not the objective of our first series to preserve residual hearing. And there's a question in the chat about light therapies in the inner ear. I cannot say anything about that, except for the fact that I heard one of these researchers talk about their work in a conference, and they're very, very serious about it, but they have a lot of burdens to overcome. It's just that we are, as I said, trying to push the boundaries. And I have to say, also, the fact that we are now involved in robotic surgery also changed the way that I perform conventional cochlear implantation. We think about concepts of speed, and we did echocochleography during conventional surgery. We think about angles and so on and so on. So I think we're getting there now. But no claims on data we have not, no.
Professor Caversaccio, anything you would like to add?
No, this is a long journey. When we look a little bit what's happened now with the robot things, with this precision medicine, individualized medicine, we are still on this journey, and but we make a more progression, I think so, and I think this is very important, and I think the precision, not only for cochlear implantation, precision medicine is worldwide. It's used in medicine. I think this is streamlined, and we are on the way to do. But I think it's still, and we see now we have the mechanical world with the biological world, and we must put this together, also with this gap between the neurites, etc. This is also pharmacological on one side, but as well electrical and with kilo ohms, etc. And I think we hope so that we can have better results in the future. This means we must have more happy patients in the future. And I think it's really fruitful and worthwhile to put energy in this field, but to bring together mechanical as well pharmacological world. This will be, I think so, the future, and I'm so convinced about this.
Good to hear that. Thank you so much. I have no further questions from my side. I assume there's nothing in the chat except for the light therapy question that was Topsakal answered already. Before we close the session, I would ask all the participants, also our listeners out there, to turn on the cameras. We have a tradition here to take a group picture together. If I may ask you all to switch on your cameras for a second, and our team here will take a group picture. Good. We have a few people who are not shy enough to. Okay. Thank you. Excellent. All right. I think we can slowly close the session. I would like to thank both of our experts here, both Professor Caversaccio and Professor Topsakal, for joining the meeting, as it was, I know, a lot of effort for both of them to get into this meeting. So I also personally thank you for that. Looking forward to seeing you and seeing your further results on this interesting topic. And I would like to invite all of you to another session of the Experts Online that we will be hosting in 2 weeks. Let me just ask the team if we can have the slide, please. Excellent. Yes. So this is the next session on November 13th. Make sure to register and join. And I wish you all a pleasant rest of the week and rest of this day. Thank you so much.
Thank you.